Tyler, how are you?
Hey, how are you?
Good, good. Can you hear me okay?
Yeah, I'm good.
Thanks for making it. We are recording these. The residents have asked.
Okay.
It's okay to record. Is that okay with you?
Yeah, sure.
Okay.
No worries.
If not, I think I can probably stop it, but our default is to try to record these sessions.
Doesn't matter to me.
Okay. I'm going to let a few more people jump on and I'll do a quick intro for you. And then
Cool.
we'll get started maybe in about a minute to 2 minutes.
Yeah, sure. I'm ready whenever.
Okay, thanks. Thanks again for making it.
Yeah, no, worked out well. Thanks for adjusting it for me.
No problem. Best to do it ahead of time than last minute.
Yeah,
Yeah. Okay, we'll give it a minute and we'll start.
cool.
Dan, good to see you. We're just waiting for a couple more of the residents and the fellows to sign on. I just texted our fellow to nudge him along. So let's see if he can get on.
Sounds good. I'll text some of the residents and remind them.
Yeah, appreciate it. Sorry, Tyler, to keep you waiting. We'll try to keep nudging a few people here and see.
No worries. No worries. I'm ready when you are.
All right. Hey, Tyler, you know what? It's 5:03. Hopefully more folks will roll in, but we'll be recording this, so we'll have it for future reference as well. But I appreciate you being here. Just as a brief introduction, many of you know Dr. Koski. He's an associate professor in the Department of Neurosurgery and in our department in orthopedic surgery. He's been a great colleague and a really good mentor and educator to our orthopedic team and to our fellows in the past, and really a key bridge between us and neurosurgery, in addition to Dr. Walensky and all the great faculty. So Tyler is going to talk to us a bit about adult deformity surgery. I'm going to do my best to keep up, Tyler. Some of this stuff gets complicated, but
I don't know.
I'll do my best to keep up. I may ask some really simplifying questions, and that's not to dumb it down for the residents. That's to dumb it down for me. So
No, please do. Please do. It's better if you do. So
all right. I'll let you share your screen, and then I'll probably go on mute. If folks are capable or able to keep their cameras on, it's great. It always helps the speaker to be able to see some feedback in real time. So please turn them on if you can.
All right. Okay. Welcome, everyone. So I've got several versions of this talk. I don't know which ones I've exactly given in the past, but they're all variations on a theme. So it's kind of a tour of some adult deformity, some important topics that I think are relevant, things I think through, that sort of thing. So I'm happy to stop and discuss at any point along the way. Just give me a shout and we'll talk.
Will do, and I'll keep track of the chat box. So if anybody has a question or a comment, feel free to type that in there. It's a small enough group. We all know each other. I think we're comfortable sort of interrupting and saying, excuse me, and going from there.
Yeah, I'm totally fine if you interrupt.
Great.
I don't mind if you do at all.
Great.
Few disclosures, a lot of implants in my talks. I've designed a few of them, but it's pretty agnostic to what you should use, at least. So adult deformity, right? When we talk about adult deformity, we're not actually supposed to say adult deformity anymore. There's a whole new push this year that's not the in vogue term anymore. So I'm gonna have to change my slides all around. But so we're talking about spinal pathologies that include scoliosis, and there's a few different types of scoliosis. We're talking about adults, so not really adolescent idiopathic, which is one of the most common types of scoliosis that you would see in the general population coming to surgery, actually. But we're talking about adults. So de novo, the degenerative scoliosis, that is really common, actually, when you see adults 70 and over. The majority of them will have a radiographic scoliosis. Now, the great minority of them will be symptomatic from it, or at least significantly symptomatic from it. Adult idiopathic, that's essentially teenage scoliosis that grew up, and iatrogenic, so something we've done to somebody to create a problem. Kyphosis, and then sagittal imbalance, which you can think of it as a kyphosis, but you actually don't have to have a kyphosis to have a sagittal plane imbalance. You can just have a lack of lumbar lordosis, which that flat back deformity is the most common type. All too often that can be an iatrogenic problem as well. And it's easy to come by, right? You can do a surgery that looks pretty good, that loses a little bit, and you build off that a couple times and you got a flat back. So this is something that's common. You all will see it, whether you are treating the scoliosis or not. Recognizing that deformity is really a big part of that. So getting an x-ray, a standing x-ray, is a part of most spine evals. If you're talking about surgery, is kind of bread and butter. You have to get that, but you have to look for the deformity to make sure you're paying attention. The sagittal plane really matters a lot. The scoliosis is obvious. Loss of lumbar lordosis a little less so. So I always start all these deformity talks with steps to correct a deformity, really, because that's how I think about it, and I kind of compartmentalize things, and we'll talk a little bit about a few of these. So identifying the deformity is really the start of it. Like, what is the problem? How bad is the problem? How flexible is the problem? What is the balance? What are you going to do from a surgery standpoint? And then how do you get fixation in a scoliotic spine? What kind of releases do you do? And then what are the corrective maneuvers? And we'll talk about a lot of those. At the end there, it says appropriate arthrodesis. So if you don't get it to fuse in a long construct like this, that can be challenging. But if you don't get it to fuse, I tell every patient, the screws will either loosen or those rods will break if we don't achieve a bony fusion. So very simple, and the very, sort of the real basic side of this, the measurement. So you will be asked to usually measure on an x-ray a deformity. Coronal plane, that is scoliosis. When you're measuring a Cobb angle, you want the biggest number you can get. Just think about that. So you want to go from the top of the upper vertebra to the bottom of the lower vertebra on the curve. And when you're doing it with a wax pen on a X-ray, you had to be pretty accurate because you didn't want to draw lines all over. Those were hard to erase. If you're doing it on the PACS, you can move that around. And if anybody watches me measure films, you'll see I simply put a line there, and I usually drag that line up and down one vertebrae just so I can see if it looks like I'm at the right one. And I'm trying to get the maximum angle because you want to measure the maximum curvature. That's your real Cobb angle. That's how big your deformity is. And if you're being really thorough, if you're measuring this curve and you said I've got a 45-degree curve from T12 to L4, you'd put that in your notes. So anybody else measuring it, even if they didn't have your film there, they can, they had 45 from T12 to L4, knowing that there is a plus or minus 3-degree inter-observer, variability theoretically on those X-rays. I actually find that to be plus or minus 3 degrees intra-observer as well. If I measure the same film, if I don't do it side by side, year over year, I tend to be a degree or two different because it's really hard to see. It never looks like this in real life. You don't have a nice flat vertebrae, right? It's a 3-dimensional structure on a 2-dimensional X-ray, and that you have to just kind of pick 2 points. So whenever I'm measuring somebody, they come in for the yearly Scolio check, I take the year before and the current one, put them side by side, and try and measure it exactly the same, kind of pick the same points on the X-ray. So I'm really doing apples to apples. And some patients are real hyper about things, and they say, well, you said it's 52 last year, now you said it was 54, but I measured 54 on both films. So I tell them it's really, that's my own margin of error, and it really matters. Does it look different when I measure it apples to apples, doing the same thing? So if you just try to get the maximum curve, you'll be right on your Cobb angle and go from the top of the top, bottom to the bottom of the bottom. Then we talk about balance. If you're talking about how much trunk shift somebody has, how far off center they are, you essentially drop a plumb line from C7, one up from the center of the sacrum, and that distance, right? If you're to the left is negative, to the right is positive, but you can just usually say, they're 3 centimeters to the right, which is how I tend to do that. Everybody knows what you're talking about when you say it like that. Sagittal alignment, again, lumbar lordosis, thoracic kyphosis, we all understand what those are. Same principle applies. Top of the top to bottom of the bottom, with one exception, and that's when you're measuring to S1. There's no bottom of S1 that you can really see, so it's to the top of S1. And when we do lumbar lordosis, most people actually measure T12 down to S1. So you include T12 in that lumbar lordosis, whether you do L1 to S1 or T12 to S1. There isn't a lot of difference because you're theoretically neutral at your thoracolumbar junction. You shouldn't have much of a difference through there. If it looks really funny, you have wedge deformities or something else, you just need to specify how you're measuring that. And that matters if you're talking about matching your pelvic incidence to lumbar lordosis. You want to measure an accurate measurement on that. Your thoracolumbar junction T10 to L2, you should think about it as being relatively neutral zone. It shouldn't have much lordosis or kyphosis. If you see either of those, there's some pathology, and you got to think, why do they have it? Sometimes that's compensatory, sometimes that's the actual deformity, but you need to pay attention to that. If somebody has a thoracolumbar junctional kyphosis, you need to really look at, can you stop a fusion in that zone? Because that is biomechanically abnormal in there. And if you stop a fusion in the middle of it, you're asking for trouble. But the numbers are what they are. It doesn't matter how much.
Hey, Tyler, can you talk about the relative contributions of lordosis between the upper and lower lumbar spines? Because I think that's really important.
I will get there.
Oh, I'm sorry. Keep going.
When we talk about spinal balance, the C7 plumb line is the most common thing people measure. What is their SVA, or sagittal vertical axis? That is from the center of the C7 vertebral body. Drop a plumb line from there, measured to the posterior superior margin of the sacrum. So the back of that sacral end plate, measured to that. Should be within 4 centimeters is what we consider the normal. Generally, when we're talking about measuring for surgery purposes, we say if they're under 5, we consider it pretty normal. So pelvic incidence is something that is, it is a must measure type of thing if you're talking about somebody with thoracolumbar deformity in this day and age. And it can be a little tricky the first time you're trying to wrap your head around it, but it really is a pretty simple concept. All you do is you're measuring the sacrum, which is almost like measuring a sacral slope. So the line at the end of the sacrum, the midpoint of that line, perpendicular to that. So you're getting perpendicular to your sacrum and then to this line to the center of the femoral heads. This angle is your pelvic incidence. That is a fixed angle because your femoral heads are in your acetabulum no matter which position you're in, and your sacrum is your sacrum, which is also connected to your pelvis through your sacroiliac joints. So if you're right side up, upside down, bending forward or backward, that number should be the same because that is one fixed unit. The two components that make that up, if you do the geometric proof, which you don't need to do, but if you take that same line, so the front half of that pelvic incidence measurement to the center of the femoral heads and measure a vertical line, that's your pelvic tilt. That is a really important measurement as well. That's how much somebody is compensating or retroverting or anteverting their pelvis to either just stand upright or usually make up for some malalignment that they have if they're out of the normal range. But a pelvic tilt changes, and it changes if you think about it because it's measured to the outside world. It's measured to the vertical. So your spine moves around and the vertical stays the same. So that's why that number changes as you rotate around your femoral heads. Normal should be, you think about around 15 degrees. We usually want less than 20 when we're looking at surgical planning. I never try and bring anybody all the way back to the absolute stone cold normal because overcorrection is just as bad, if not worse, than undercorrection. Sacral slope, it's important to know it is measured to the horizontal line. So it's this angle of that line measured to the horizontal. That tells you, it gives you an idea of how big your pelvic incidence is, right? As it really gets pretty verticalized. You have a high pelvic incidence, but you also get a lot of shear force at that L5S1 level. The higher that angle, the more risk of having an isthmic spondylolisthesis you have. So it comes into play there, but it's not something that I normally measure as a part of a measurement because it doesn't factor into my correction, where pelvic tilt definitely does. Cranial center mass, it's something we came up with a long time ago.
Tyler, can I interrupt you and ask you a quick question? Can pelvic tilt or sacral slope be trained? Meaning that I know the pelvic incidence is fixed, but since can you with physical therapy change those things?
You can, and it's usually because you get hip flexor contracture. So if they have a hip flexor contracture, somebody that has a lot of pain, has some kind of issue, and they're really not a big ambulator, they sit all the time, and people that can walk but prefer to take a wheelchair, I see it a lot. Patients that come in, they have a deformity, they've been more or less non-ambulatory for a year or two, and they've got hip flexor contractures, and so they can't stand up and retrovert their pelvis. So their pelvic tilt is really low, and they have a deformity, which is always a red flag. Right? Somebody should have a high pelvic tilt if they have a deformity because they should be trying to make up for it and trying to stand up. If they're failing to do that, you got to look at see if they have a hip flexor contracture. So by stretching and releasing, you can get them better able to compensate through that. I don't know that you can train somebody that has a deformity to say have a really function well with a really high pelvic tilt. I don't think that's a functional thing. It's more, can you get them back to be able to have some range of motion for some adjustment there? Does that make sense?
And so you're probably going to get to this, but I just in case you're not. So, when you get to your formulas later about your lumbar lordosis and your pelvic incidence, that's what you're sort of really looking at and how you're balancing things, right?
Right.
And if the patient's on the table and you match those things up right, theoretically, then your pelvic tilt and slope shouldn't matter that much, right?
Right. So in surgery, I don't measure those things because they're not standing up, right? So they're right. If they're measured to the vertical and the horizontal, they're not standing up. It's right. You're just guesstimating it.
Yeah.
I calculate how much lordosis do I need through a certain zone to match what they have when they stand, and then I measure that.
And so if you have somebody with a deformity, though, I guess the key is that you're able to somehow get them to stand without them bending their knees or hips, so that that tilt and slope is accurate. So even though you're really going to base it off the pelvic instance.
Yeah, if they're bending their knees and hips and all the things that people do to compensate, and you take the X-ray, that shows in the pelvic tilt, though. Back when I was doing my fellowship here, it was common that Dr. Andra would like get an x-ray and we'd look at it and he'd be like, oh, this person's like bending their knees and they're leaning over, because it was a Scully film. We didn't have the luxury of an EOS where you can see what their legs are doing now. And he would send me back down with them to watch them do that and make sure I'm coaching them on how to stand down there and doing all that, which was always a lot of fun. It really shortened the day. And but you had to, because you had to measure that, and it was a little hard to do that. The better we understand sort of pelvic tilt and how that adjusts, the easier that becomes. And you can, I'll show you a measurement in a minute that shows that well as well, because it's an angular measurement, not a not like a numerical measurement, which some of these are. So cranial center mass is another one to use. We wrote a paper on this. Essentially, where your head sits is really what you're trying to balance. That right, C7. Nobody cares where their C7 is. They care where their head and eyes are looking. It was hard to get in the past because it got cut off on the films. Now that we have better films, you can measure that, and it's just another measurement. But that won't be on anything you ever get tested on, at least not at this point. But you can calculate that in there as well. Here's a guy that had a huge deformity. You can see all the problems here, right? So you can see he's got a flat back. He's got a thoracolumbar junctional kyphosis. His pelvic incidence is high. This angle is high right there. And his pelvic tilt is super high. That's supposed to be 15 degrees, right? I mean, that's like 50 degrees there. That is a huge number. So even though his plumb line falls here, his deformity, because this is so high, is way worse than that. He's a guy that when he walks, he is bent in half. Right. So somebody can stand with a retroverted pelvis for an x-ray for 30 seconds to get the film and it looks okay. But they're the kind of people that they kind of stand up in the office, but if you watch them walk down the hall, they don't get, by the time they get to the end of the hall, they're way bent over if they don't have a walker or something, because they just can't walk like that. You can't walk with a retroverted pelvis. It falls back neutral and deformity really comes out. So cranial center mass should be a little bit in front of your C7, but balancing pretty well. And that's a guy that took 2 3-column osteotomies to get him lined up in a whole lot of rods. So this is what I was talking about. This is the T1 pelvic angle. This is an angular measurement. Essentially, it is, this version is like the line of the first part of your pelvic tilt. But instead of going to the vertical, it goes up to the T1. So it's an angular measurement of where. So it looks at you, it's kind of like a C7, plumb line, and SVA, and a pelvic tilt all rolled into one. Should be less than 14. Kind of 0 to 14 is the range for that. You can see a nice example of this on the same guy there. So as that corrects, that's nice to use. You theoretically, if you had a good enough x-ray, could use this in surgery if you wanted to measure that. That's an angle you probably could get if you could get enough on there. We don't have it yet, but I'm been pushing. The O-arm has a new Scully feature that it's a software package that just goes and you can just like click fluoro shots and it will generate an x-ray that looks just like this. And it's pretty remarkable, where you could actually measure those things if you wanted to. I'm not very good at factoring that into my correction. How many degrees do I need on that to get there? Or do I just add that together? Because, right, this angle is down here and I'm correcting it through here. I'm sure I could figure it out if I thought about it, but I kind of like what I do, so it works. So, but it's a smart angle if you're willing to use it. So this is what Alpesh was asking before. This is something that's come out in the last several years called the GAP score, Global Alignment and Proportion Score. It is a very complicated model of measuring all these different things, trying to figure out how your spine really should be, and it's spinal pelvic harmony. Like how does your own pelvis and your alignment correlate to how your lumbar lordosis and the rest of your spine is. But the key concept here, one of these is where your lordosis is. And the key is, if you look at this, getting your lordosis from 2/3 of it from L4 to S1 is incredibly important. It is the normal way your spine should be, right? You should have 2/3 of your lordosis from L4 to S1. But when you do a correction, people used to do a lot of PSOs at L2 and L3, and there was a ton of PJK in those patients. It's because they were putting the lordosis in the wrong spot. The numbers all matched, and people stood up straight for a while, but they tended to lean over because the mechanics of it are just off. It is it's a complicated score that has all these different categories. So there's like this relative pelvic version, relative lumbar lordosis, all these different subgroups, and you add all these scores together. It's I mean, it's not the hardest thing in the world to do, but it takes time. And it's not something that most of us do on a regular basis. If you could automate, a measurement software to do that would be really helpful and could give you a nice score. And they did a study that confirmed, right, the people that came up with the score did a study, and they're super smart people. But it showed that if you have a gap score that's really low, you never have a mechanical failure. If you're in the higher categories, you have almost a 100% mechanical failure of your construct. So either rods breaking or junctional kyphosis. So it goes to tell you, if you get it right, it matters a lot. And getting that lordosis in the right spot is a big part of it. This lordosis distribution index is really, really important. If that makes sense. So when we talk about goals, coronal, you just want to get them lined up. So head and shoulders, balance of spine, so C7 over the center of S1. Sagittal, a little more involved and much more important. So I want the SVA less than 5 centimeters. I want the lumbar lordosis within 10 degrees of the pelvic incidence. And I'm usually, unless it's a really low pelvic incidence, I want it on the underside, right? It's supposed to be plus or minus 10 degrees. If the pelvic incidence is 60, I want 50 or 51. I don't want really any more than that. Pelvic tilt less than 20 degrees and 2/3 of the lordosis up forward S1. If you do all of those things, patients tend to do really well. And I think the junctional failure rate actually is pretty low. So getting away from some of the measurements, which is a big part of that planning, but thinking about why do you operate in these patients is a whole nother lecture, and I won't spend a ton of time on this. But patients coming with back pain is hard. Back pain with scoliosis and sagittal imbalance and other things is a little less hard than degenerative disease back pain, which is nice. It's just a lot more work to deal with these people, right? There's a lot going on there, but it's a little easier to figure out why they have pain. Correcting the pain, again, is a whole nother ballgame. But leg pain is far easier to sort out than back pain if they've got a nerve that's compressed. Interestingly, on deformity patients, you have to really pay attention to their MRI when they're supine versus their X-rays when they're standing. You can have somebody that can have a pretty significant radiculopathy with an MRI that doesn't look too bad. If they're collapsing down when they stand up, and if it's on the concavity of that curvature, they can really close down foramen that you don't see when they're supine on MRI if they have a lot of flexibility. Same thing with a kyphosis. I've seen patients that have a pretty significant, even cervical thoracic kyphosis. They've got a really head forward posture that they have to really hyperlordose their lumbar spine to get their horizontal gaze to be able to look forward. And they get a lot of back pain and radiculopathies. They close down that foramen down there, and you get an MRI and they're lying down, it all bends out and it looks pretty normal. So it can be interesting. And the difference between supine imaging studies like CT and MR and standing films are really important. Looking at, can these patients have surgery? Again, a whole another ballgame that maybe we won't get too much into that today. So when I look at adults, and I tell adults that come in all the time, people come in and they don't like having scoliosis. They don't like their curve. They don't like that their waist is asymmetric and they lean a little bit. But the cosmetics of it are important to get right if you operate, but they're a pretty bad reason to operate on somebody, because the stiffness that comes from this operation is abnormal, and people won't like it unless you give them something in terms of pain relief and function in doing that. So number one is pain, by far the most common. Usually that's back pain that they've had for a long time that is now turning into back and leg pain. That's when people really start to have trouble. They can lifestyle modify a long time with some back pain, but when the leg starts to kick in, they start to struggle. Neurologic issues, meaning you're starting to get some weakness or other issues related to that. Pain comes before weakness 95% of the time, so it's usually a pain syndrome or radiographic progression. That is something that you can see. We measure adults. I check people on a 1 year, 2 year, 3 year, 5 year basis, depending on how old they are and what their curves look like. And we measure them. Somebody comes in and they're 3 degrees more than they were the year before. I worry about it a little bit. I shorten their interval to 6 months, get it again, and check that. We always talk about adults having a 1 degree per year sort of progression is considered normal. But if you took somebody that had a 45-degree curve and they progressed a degree per year, it's not going to be very long, and they're going to have a pretty darn big curve. So I think you can see a degree per year sort of if you look at somebody, they haven't had a film in 5 years and they're 5 degrees more, you'd consider that within the normal range, but I'd still check them a little closer because people tend to either be pretty stable or start to progress a little bit. But it's rare that people progress without first having all the pain. Most of the time it's pain that gets them, they can have pain and some progression, pain and some neurologic issues, but it's pain 98% of the time, I think, in my practice. And curve magnitude doesn't matter to me. It's not adolescent idiopathic scoliosis where they hit 45 or 50 degrees and you sign them up for surgery. That is not the case in adults. So I tell all of my adult patients, when you're a teenager, it's a preventative maintenance surgery. You're trying to do something to prevent problems as an adult. Once you're an adult, we're kind of living the natural history. We're going to see what happens at this point. The preventative maintenance is gone. We're riding this train and we're going to see what happens. That being said, if somebody has a pretty large curve and they're not doing very well, and I know it's going to get harder and harder to fix if we let it go, and I'm at risk of progression, I might have a lower magnitude. If I've got a 26-year-old and they're like 70 degrees, okay, I'm probably going to have a lower threshold to do that because I know it's going to get really, really hard as that stiffens up. But I tend to even watch that for a little while and see how get to know them a little bit and see how they're doing. So deciding on the magnitude of surgery, all of these scoliosis patients don't need scoliosis surgery. Some people come in and they've got a lumbar, real common, they have an adult idiopathic curve. So they've got a Lenke 5 curve, a thoracolumbar, lumbar curvature that sort of ended at L3, and now they have like L4-5, degenerative disc disease or disc herniation, or L5S1 foraminal stenosis or something. And then, so I look and say, well, can I just address the minor problem and not address the deformity? Kind of my rules are right here. Can I address the symptom without correcting the deformity? Meaning, is this concavity stenosis due to scoliosis where I have to lift it up? Or is this something at a fractional or the lumbosacral curve like L4 to S1? If I do an operation, am I going to set that deformity off? So do they have a disc herniation or stenosis at the apex of a mobile curvature where I'm going to just weaken it if I go in and decompress that? And I'm going to create a problem. If I do this operation, am I going to make it harder to fix in the future? So if somebody has a L4 to S1 deformity and I fuse them crooked, like I definitely made that next operation harder if I needed to do that, which I'm always sad when I see that come in to my clinic because it makes it really hard to fix the actual deformity if we need to. And how will the patient tolerate a second operation? If I'm setting them up for something saying, well, they're not a great candidate for this big surgery, and I'm going to do something small because I'm going to try and get away with something. If I start that snowball rolling down the hill and they're not a good candidate for that, you got to think about that before you push that first snowball, because one thing can lead to another, and then you're in trouble. Just an example that I show all the time: 67-year-old back and leg pain, but mostly leg pain with this disc herniation, and it's out kind of into the foramen, tracking along that nerve there. She's got this curvature, so her problem is here, and her deformity is here. So we're not in the main curve; we're in that fractional curve. Her sagittal balance isn't great, but it's mostly from this kyphosis here, not down here. So for her, I did a single level MIST lift, tried to level that out as much as I could at that segment, which works very well, is reasonable. It gives people relief of their current symptoms and doesn't give them the stiffness from that fusion you'd otherwise give them. So that's really useful. And I think it's a very reasonable thing to do. I do that fairly regularly. I always tell people that I'm trying to do something that I can build off of in the future. I'm trying to level that out as much as I can, because if you fuse it really crooked, then that curve becomes necessary because you're fusing the compensatory curve, and then you can't fix the main curve. So if they ever have problems there, you just have to fuse it curved, which is, it's harder to do than you'd think. Like it's hard to keep it balanced in that scenario. So when do I do something small? If it's primary radicular pain, you can do decompression if you're not going to destabilize the curve, which is really nice. Doing it minimally invasively, even better. Being below the apex or that fractional curve, and again, minimally invasive techniques can be helpful because I think they're tissue sparing, which helps. We put this treatment algorithm out back when Randy was with us. We wrote this up for something, and this is the they can have a decompression, right? There's a lot of, oh, go this way, that way, and all this other stuff. If they meet some certain criteria, they don't have instability, that we think it's a single nerve and it's not in the main deformity, then you can do a small decompression procedure.
Hey, Tyler, can I ask a quick question there?
Yeah.
I appreciate this algorithm. The one that I was taught, all the arrows led to a front back fusion. That was pretty much our algorithm.
The Bridwell one?
Because, exactly, right? That
Yeah.
was what I learned from Bridwell, was everything's a front back.
Yeah.
But at the same point, they do work well. So I'm wondering, I've been faced a lot of times with these fractional curves, 4-5, 5-1, foraminal stenosis, just that pattern that you showed. And I go back and forth on, should I try to do something, small posterior based MIS, let's say decompression fusion, or an ALIF. And I tend to go towards the ALIFs because I feel like you do get to level them out a lot better. You get to build in lordosis a little bit better. And then I'm thinking, if I do need to revise them, hopefully I'm already fused down to S1. And I've got a solid fusion. What do you think
Absolutely.
about how aggressive to get on that first procedure?
Yep, all that is true. I do the same thing, but I'm an ALIF and TLIF kind of guy. I like TLIF as well. If it's L4-5, it's pretty rare for me to go in and do a 4-5 ALIF alone and then posterior, right? There's just more risk in that. There's more mobilization of the vessels. There's more downside to a 4-5 ALIF than there is a 5-1 ALIF. If I'm doing both, right, fine. I'm already going to be there at 5-1. I'll kind of include 4-5, but I tend not to go for 4-5 on its own. And I tend to TLIF the 4-5. That's just my own bias. You need a little less lordosis at 4-5 than you do at 5-1. Right. So I'm a little more comfortable with TLIF. And I mean, I'll do 5-1 TLIF as well, but you see a lot of 4-5 pathology in these patients, and I tend to TLIF those. But 4-5, 5-1, particularly if I really need foraminal height or I really need to build in some lordosis, and I'm trying to build a solid foundation for the future, I will go ALIF with some perk screws or something in the back. Yeah. And then you may be getting to this, but are you, and this might be the next slide, but predictors of failure of conversion to longer fusions. Yeah,
right?
I think
I've done a fair number, and it doesn't seem to happen that often if the patient's chosen correctly, that you end up rapidly having to bring them back. But I'm wondering what you've seen and what the evidence shows.
Yeah, I mean, I think it's just essentially the opposite of what my sort of indications or criteria to do that, right? I think if you don't follow that, the criteria of when you can go short, I think that's when you start to have problems. Maybe you'd add in things like osteoporosis and other things which you need to be careful with about fusion anyway. I think if you need a ton of correction at those levels, if it's really flat and you're trying to get a lot of correction at those, it's probably not going to work. If you're just trying to, if it's more of a radiculopathy, you're trying to elevate foramen and level things out and try and treat, or a degen spondy or something like that, it tends to work pretty well to go short there. They get adjacent segment degeneration like anybody would after a fusion, but it just tends to be, we have to, like the revision surgery tends to jump to the big one pretty quickly, as opposed to just creeping up level by level. That's at least how once we creep into the curve, then I do the curve. If we can stay below it, I'll stay below it as long as I can.
And I think just for your knowledge, as you look at these, because he and I talked about this earlier this week, if you are going to go short, what Dr. Koski just said is really important. If you have to go back, don't do that one level creep that we see over and over again, right? Add a level, because I think that's where we see a lot of problems, both in the creation of iatrogenic deformity and non-unions, but then also really bad functional problems for patients.
Yeah, absolutely.
Sorry, I'll let you keep going. I'm sorry to cut you.
No, it's right. It's one of those things where it's great when you can stay short and do something small, but I always think you need to look to the long term. Like, what is that ultimate operation going to look like, and how am I going to do my best job here to make that easier, should we need to do that, as opposed to harder. I think that matters a lot, because I definitely have seen it been on the wrong side of that. So from here on, I was saying, we're assuming short isn't an option, right? These are people with problems in pathology that you're trying to work up for deformity. And this is a key portion of how planning a construct here, and a concept just for deformity in general and any correction is how flexible is it? Because it makes a huge difference in terms of what you're doing. So we get x-rays and radiographs, and standing x-rays are sort of the gold standard we get, but all of these other ones, supine or supine side bending, are really helpful. Push prone traction, and quite honestly, just getting a CT scan where they're lying down, you can look at the scouts, and you can do a lot of that. I don't oftentimes send people for supine films if I'm getting a CT, because I look at that first. If I think I need something like a bolstered film or a bending film or something, okay, we'll do that. But I usually just get the CT first now, because I can get so much information from that. It just tells me how much flexibility I have and helps me plan my day. You know, if somebody has a lot of flexibility, there's a lot of things I can do to get that right. If they're really stiff, I know it's going to be a lot of work to try and get that to move. And sometimes I have to change the plan where it's not going to work to get them move, and you have to change that plan. I always show this one. It's a really nice example of flexibility on a CT scan. Standing film, this is an iatrogenic deformity. Somebody had a decompression infusion, they loosened their screws. What do you do when your screws start to loosen? You pull them out so that nobody can see them anymore, right? That helps you, not the patient. So this patient keeps slipping, and she develops a grade 4 listhesis and was a miserable person. Like, she was in so much pain. Like, couldn't stand up, couldn't do anything. It was sad to look at her. But her CT scan, look at the change there. Look at how much it comes back when she just lies down. So she's having so much pain because it's slipped, it's malaligned, but it's loose. It's moving around like crazy on her. So it goes from a grade 4 to a grade 2 when she lies down. So all I do is cut a little posterior column osteotomy to release the nerves, and it lines up really nicely, and it looks really good without a whole lot of effort, right? I mean, I knew I could just release that and pull on those screws and pull it right back to where we wanted it to be. Here's another one. Looks like a pretty significant deformity. It's kind of what we call ribs on hip over here. Sagittally, really bad with, it's hard to see here, but a really high pelvic incidence. This is an atypical spine. This is somebody that's this is an adult idiopathic deformity, but has some just congenital oddity in terms of her alignment. But when she lies down, look at how much better that looks. Look at the difference between the ribs and the pelvis here. That comes down quite a bit. So we get her to bend aside, that gappy gets even better. I mean, you can go in and measure these curves, but I just tend to look at what we're doing through here, knowing that it moves quite a bit. And then, you can instrument her, and she comes around pretty nicely, just with some little facet releases, not even big true osteotomies to do that. Now, she looks funny with this huge lordosis. It's too high. The lordosis should be more here, but look at her sacral slope here is super high. Her pelvic incidence is really high. This worked for her, but it worked for her because I'm all the way to here, right? If I would have tried to stop this here, she would have junctioned with the lordosis built in so high. That's my belief. I got away with it because I took her all the way up to the top. So, right, the more flexible, the better correction, right? You can look like a really bad deformity. If it moves, you can look like a hero. Here's another one, a little old lady, more of a degenerative scoliosis. A similar look in terms of, she's leaning the other way, but the same sagittal plane issue, the same coronal plane issue, being ribs on hip here. When she lays down, not much of a gap here, a little stiffer in that. So she's somebody I cut more of an osteotomy. I did a little more work through that, knowing I had to really get it to release through there. She's got A-lifts in there, but these were done post correction. These were fill-in A-lifts done at the end. Her deformity correction is up here, so it didn't really help me, but I gapped those up open, and I wanted to come back and fill those in secondarily. Another adult idiopathic, big curvature, kyphoscoliotic through this area, and stuck, right? She bends, and this thing is like the same curve no matter which way she's bending, and you can see why in the CT. It's just bridging osteophytes all over. Little lateral listhesis with a little vacuum phenomenon here and here. I know those are going to move, but if this moves and this doesn't, I got a problem, because she was relatively balanced to start with. So she gets a lot of posterior column work through the area here and here, not so much through here, right? You can see these screws, how she's still rotated through there. I had to leave that as it is, or I'd have to come in and do anterior releases or all kinds of other things that just aren't worth it, because she balances nicely and actually does really well. The goal of the surgery isn't to make her spine straight, it's to make it balanced and stable with nerves that aren't pinched, right? If you do all those things, patients do well with this. So again, those goals of doing that, coronal, getting them balanced, SVA less than 5 centimeters, PI minus LL within 10, and then pelvic tilt less than 20. And again, 2/3 of that lordosis, just reiterating the important numbers to think about and remember from this. This is a lady here, had an old Harrington rod construct, flat back. That's really a common thing we would see. We kind of seem to have run through most of those patients. There's less of those now, but 10 years ago, there was a lot of these people coming around. She was one it was easy to measure just because she was so fused through here. So you can see her SVA is really high. Her pelvic incidence was 58, her pelvic tilt was 35. And we used to do this trig where we sort of do this angle and say, if I had this patient and I cut an osteotomy here, how many degrees do I have to get to bring this point to this point? And it's an angle you can simply measure. And that for her was 35 degrees. So if I do an PSO here and get 35 degrees, and her lordosis is 0 to start with, what do I need? So I need 20 more degrees to get her into that range. And so I did a ALIF where I got 20 degrees, and then 30-degree osteotomy, we get that 50 degrees of correction, and we really get what we need to get there. You can see that all there. So you can see a hyperlordotic ALIF done before hyperlordotic ALIFs existed. This is me taking a peak spacer and drilling down the back of it and making my own cage, much to the chagrin of the reps always, and then the 3-column osteotomy. So let's get that for right now. So we do all of these, and you see these patients. One of the hard parts about these deformity patients are they come in looking like this. This is a super rotated spine. And you say, okay, that's going to be a lot. I'm going to have to really do a derotation here and pull that around, but I need something to go in there. Then you get a CT scan and you see that it looks like this. And not only is that a tiny twig of a pedicle, but it's rotated so much that this is that same screw going in. Sorry for the shaky video, but watch the angle that I'm putting that screw in. Like that should be going straight across her spinal canal in a normal patient, right? If I walked into the room and saw somebody putting a screw in like that, I'd be like, stop, 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 like you're causing a problem. But when it's rotated like that, you need quite a bit there. And so that was that screw going down that pedicle. And to do that in a deformity patient, right? That's a freehand screw. There's no nav or fluoro or anything else going on there. That's a freehand screw. And right, that's just kind of what you have to be able to do, is get those screws to go down those bones if you're going to have any ability to pull that around. Now there are other adjuncts, people use hooks, or now we have those. If you see that like Versatile system that I use for like PJK stuff, that really is a sublaminar band. All those like PJK tools we have that different companies make, those are FDA approved as sublaminar bands, which you could put a sublaminar band and pull on that, which is kind of an old school technique, but that does work. But if you can get those screws in there, then you can derotate that spine around and get it to be really pretty straight. So those screws, right? If you miss that screw, what are you going to do? Most of the time, somebody blows the screw into the canal and it's medial. What do? I leave it out. I don't need every screw, right? On these patients where you've got T4 to pelvis, T3 to pelvis, I don't need every one of those screws in there. I need most of them at the apexes of the curvature on the concavity, because I'm going to pull on that a little bit, but I don't need every screw. So leaving it out is the number one thing that I do. If you need the screw, you can try a different trajectory. You can decide using hooks, or you can try wires or sublaminar bands, or if you can get something in there and cemented, try in, out, in. Just know that all of these alternatives, you lose 30% of your fixation, right? So when you miss a screw, that revision screw, only 66% or something as effective as that first screw in terms of what you can put on it from a force standpoint. So when we talk about correction, that's right. So all the different steps to correct a deformity we're talking about. Now we've figured out what we have, figured out how flexible it is. We have all our screws in. We've maybe released the bones a little bit. Now, how are we going to correct it? That's all about using that instantaneous axis of rotation, right? So as you apply a force or a moment to the spine, how is that going to rotate in space, and what are you going to do? And understanding how you do that. So whether it's compression, distraction, translation, derotation, we're all rotating the spine about a point, and we're oftentimes adjusting that point based on what we're doing. So most of the time we're trying to add lordosis. Very rarely are we trying to add kyphosis in scenarios. We do, but it's much more the opposite. So it's usually shortening the posterior column. Lengthening the anterior column, we do it L5S1, L4-5 with an A-lift quite commonly. We don't want to really lengthen cord level because that can cause problems. We don't want to stretch the cord. So shortening is safer than lengthening, but lumbar interbodies are anterior column lengthening. If you just lengthen the anterior column and don't shorten the posterior column, though, you don't get as much as you would if you do them both in combination. And the concept there is that axis of rotation, usually when we're doing a posterior compression with pedicle screws, kind of that posterior third of the vertebral body is where it's rotating around. That's why you're adding lordosis. You can just see that there in that vertebral body, or it depends on how you place the force, where that's going to rotate. I mean, if you think about just any object, if you hit it on the top, the bottom side, like things move differently. The same thing applies to your spine. The difference is in the spine, we're kind of fixating with pretty similar implants, right? With pedicle screws at all those levels. And so we tend to have a pretty consistent axis rotation with certain things that we do. So again, anterior correction of scoliosis was a very common thing, then became a less common thing. Now people are tethering, so it's a common thing again. Different technique, but essentially it's always an anterior compression. So you're compressing in front of the axis of rotation with screws that go across the vertebral body. And if you compress in the front, you shorten the front and take out lordosis or add kyphosis to that. So you always have to be careful. So if you're doing that in the thoracolumbar junction, you want to make sure you're not making it kyphotic while you do that. You want to make sure you're kind of keeping that neutral. Things you'd have to plan, but not that I think anybody's going to go and do this operation. It's just a good example of how you're impacting that axis of rotation. And you really need to think about that when you're thinking about how to correct a spine. We can sort of augment our axis of rotation by cutting posterior column osteotomies, whether it's Smith-Peterson or Ponte. I won't get into that, but it's cutting essentially through the infraosteal lamina out through that facet. So the facet's released, the ligaments released. We're loosening up that. And I always tell people, they're like, oh, how much correction do you get from a SPO? I'm like, you get none, right? If you cut it, you get probably a degree per millimeter of closure. So, right, if you cut these, it looks just like this. If I squeeze those together to their backbone on bone and I've shortened the posterior column, you get a correction of that kyphosis. So that, again, the SPO or Ponte, it's easier to call them posterior column osteotomies because you don't have to use any of the names. Resection of all of these. Interspinous ligament, inferior edge of the lamina drilled out in a chevron shape, or kerrison, however you want to do that, out through that facet complex. The top of that superior facet is a key. That's something I always teach. If you leave that in, because it can kind of be like a little loose rattly fragment, and you then close that down, you essentially left a free floating piece of bone in the neural frame, and then you squeezed on it. So you end up with radiculopathy, or you risk radiculopathy in doing that. So you need to make sure that piece of bone comes out. And then ligament deflatum, so it doesn't buckle into the canal when you close that down. So again, compression distraction, pretty straightforward. You're stretching it out or compressing it either on the convexity or concavity. We can significantly alter that axis of rotation by doing something like a pedicle subtraction osteotomy, where instead of having that axis of rotation in the posterior vertebral body, we cut a hinge point in the front and essentially create that as the axis of rotation. So it gives us much, essentially a longer lever arm of more shortening we can do in the posterior column. So you can get quite a bit of shortening, up to maybe 30 or even 35 degrees if you're really stretching it, which gives you a real focal change. Again, this is what they always used to look like. This is what we did PSOs like this all the time. It's away from the lower lumbar roots that are so sensitive. It's not so deep in the lumbar spine. It's a beautiful level to do an osteotomy. It just led to a ton of PJK because we put the lordosis here and the construct ends here, and I'll guarantee you that person had some junctional kyphosis. We didn't know that back then, but now we do. So PSO, again, it's not a PSO talk, so we don't talk too much about that, but it's resecting the entire pedicle. I see a lot of people come in that have had a PSO and they somehow still have a pedicle. So I don't know what got subtracted, but it wasn't the pedicle. And when you do that, if you close it down like this, then you create foraminal stenosis. So you need to remove that pedicle so these two nerve roots can live in one super foramen. it is common to want to have inner bodies at those discs. If you have big mobile discs above and below, the rod fracture and pseudo rate is really high. We add 3 or 4 rods across them, but you still can break those rods. Most of the time, PSO should be done in a spine that's already fused, so you don't really have that problem. But some people put an inner body spacer in those disc spaces, or take the disc with the osteotomy, which is a different type. It's a Schwab grade 4 versus grade 3, just variations on a theme. This is a Schwab grade 4 where the disc came with it essentially, and it leveled down there. So then vertebral column resection, removing a whole segment, very much like a vertebrectomy you would do for trauma or tumor sometimes, where you're removing similar structures. The big difference between a VCR and a vertebrectomy or corpectomy for those other pathologies are, in those you're trying to reconstruct the anterior column, right? You're removing something and trying to reconstruct that anterior column. In a VCR, you're trying to change the anterior column. So it's similar mechanics of what you're removing, but very different in terms of how you rod that. And so, people say, oh, I'm doing a VCR for tumor. And I'm like, no, you're not. You're doing a corpectomy or vertebrectomy or spondylectomy or whatever you're doing. Those are, the different words exist because they're kind of different operations. So a VCR is a shortening operation where you're trying to really change that alignment by shortening that all columns, but you're really trying to shorten the posterior column more than the anterior column in that operation. And again, that's done where you have a kyphotic segment. Again, so if you look here, the spacer that I put in, I usually want it to be about half the size of the defect I made. So I start to close it, start to let it go anteriorly, figure out what's going to kind of just fill that space, drop a little, usually oftentimes a little T-lift cage, a little a mesh cage, like a Harms cage or pyramesh cage. Sometimes just a piece of bone, like rib or things like that in there, and then complete that closure. So it just kind of keeps that anterior column lengthened right at the very front and can close down on the back. And this is usually a thoracic level operation. Really hard to do this in the lumbar spine because the thoracic spine is kyphotic and we're trying to make it less kyphotic. Perfect for this. The lumbar spine, if it's flat and you're trying to make it lordotic, you can't get that cage to sit in there because in a VCR, you're taking all of the bone out. And so as you start to make it lordotic, that cage is no longer tight in there anymore. It wants to spit out the front. So you end up in a situation where you can't add the lordosis you want without your cage loosening, and then you're in trouble. So this is primarily a thoracic operation. So again, another maneuver, translation maneuver. If you think about minimally invasive scoliosis where they have all those towers on there, those are all translation maneuvers. It is putting a rod in and dialing that back and trying to pull the spine to the rod. I use that all the time in adult deformity, where I do a translation maneuver where I put those extension towers on those screws on the concavity. Usually the concavity is sitting lower than the convexity, and I call it a translation derotation because I'm trying to pull the spine over and up when I do that. And so I start to take those towers and they're kind of angled like this, and I'm pushing them up like this, which is lifting that spine up as it goes. It's a coupled maneuver and it works really well as long as your fixation is good and your spine is mobile, right? If either of those things aren't the case, don't pull very much because you're just going to pull your screws and then you're in trouble. Again, that's just a translation of bringing the spine to the rod in that little artist description of that there. So old-fashioned techniques here, you should do it with wires is common. So it gets kind of a good idea of how that goes, where you put those wires around and they like twist the wires, like keep twisting. And as you twist it, it gets a little tighter and brings that over. We can do that now with those sublaminar bands, which they have little tensioning devices. You can dial that back, but we usually do that with pedicle screws in this day and age. We'll skip that. So in situ contouring. So after the spine is instrumented, tweaking the construct. I try to not use this as my real main correcting technique because it just weakens your rod a little bit. But after it's done, I get a film. I don't quite like it. I might come and do a little bit of tweaking with some coronal benders or things where you loosen up the screws, push the spine around one way or the other, trying to readjust that coronal plane a little bit can work well. But just know that every time you're bending that rod with those, you're adding a little bit of a stress point to those rods, and you can weaken that. Well, if I do a lot of coronal bending, if I did a ton, I would get it all to where I want it to be, lock one rod down, take it out and put a whole new rod in there. So I don't have, so I start with a better rod to start with, or I put auxiliary rods, a third or a fourth rod across there to take up some of that force. Getting there. So if you know what a cantilever force is, this is something that we do pretty commonly. It's nice to add lordosis in the lumbar spine. You bend a rod into lordosis, fixate it at the sacrum and pelvis, and push it down. It kind of pushes the spine into lordosis as you do that. You add that force, and or essentially you can see the picture here where the axis of rotation is coming towards the rod, right? The axis of rotation moves towards your implants is sort of one of the concepts there. But pulling that, would I do that with hooks like this? This is a Sherman's kind of picture. No, probably not. That really is going to pull on those quite a bit. But doing when you're fixated sacrum and pelvis, you can push a lot of force and you're not going to cause too much problem. Let's get that. A rod rotation. Put in a rod that's curved to match the spine, and you, right? So scoliosis is a rotational problem. Essentially you have a coronal curve instead of a kyphosis in the thoracic spine. You put it in there and you rotate that rod around. It actually works. It's kind of the original correction technique. Now we do more of an apical derotation where we actually put the rod in and actually set up this whole thing and connect everything together and derotate those segments, which can work quite well, but that's a more advanced technique as well. So things to think about here, right? Have solid indications, know why you're treating deformity, make sure the patients are ready. They understand, like there's a whole nother talk about how bad is the surgery and what are the risks and getting them medically prepared, but you just know there's a lot that goes into that. Think about what you're doing, why you're doing it, plan your surgery properly, measure your films, assess your flexibility and plan that appropriately. And there's a lot of reasons that I won't do surgery on people. And that's a whole nother talk as well. Whirlwind tour a little bit. Hopefully some of the basics were there. And then a little bit of some of the nuances of how that plays into how we actually go about correcting things. And, comments, questions?
Yeah, thanks, Tyler, for the lecture. I thought it was super helpful. As a resident fellow, it always seemed like, the measurements that you mentioned were like super helpful in kind of thinking about it. But then as we go, like every year, the ISSG always puts out papers with the ever more increasing measurements. And to me, just the topic can get quickly confusing. So I think you kind of, like you had it right, just kind of stick to the principles and the basics and you kind of think about it that way. But I think you also alluded to a lot of work goes on behind the scenes before you actually even operate on the patient. So I think there's a lot going on there. So, a lot of principles to pick up for like the residents and fellows. I think Dan had a question in the chat. I wanted to make sure that you saw. So he asked, Dr. Gassi, you mentioned not operating on a particular magnitude of curve. In residual adolescent idiopathic scoliosis, what curve magnitude do you tell the patient that they're at a higher risk for progression, so you may have a lower threshold for correction?
I think that 45 to 50 is the range they use for the adolescents, and that's right. If you think about it, something that's still kind of growing, or right, they're operating on teenagers that are becoming skeletally mature, so they're mostly done growing, but might have a little bit more growth. Patients that are at that level at that age tend to have a much higher percentage chance of having some problem through adulthood. That doesn't mean that there aren't people that have a 50-degree curve and are going to be totally fine. It's just that that's where they've drawn the line, is saying, okay, the risk is high enough that we should treat this up front because it's going to be easier to treat now than it will in the future. I see a lot. So I only treat, I'm at Northwestern, we're a 16 and over hospital. You can do 15 with an exemption, but that's as low as they'll go for you. So most of the time those, adolescent idiopathic scoliosis patients are getting treated at 12, 13, 14 years old. So they're getting treated before they see me. I see people that fall through the cracks that now are 18, 19, 20, and they're 50 degrees. I don't usually operate on them at that level. They've kind of made it through that zone and see, like I tend to follow them fairly closely. I will see people that are like 55 or 60 degrees and they're like, oh, I'm a freshman in college and I'm coming home and it bothers me and I want to have something. I'll do those because they're still, right? If they're, high school kids. They're scalably mature, but they're still, teenagers, and have a curve that is well above that threshold and it bothers them. That's reasonable to do in my mind. I think I kind of stretch that. So, somebody's in their 20s, like they're out of college, they're sort of out on their own. I usually counsel people like, we should just watch this and see what happens. Nobody really likes their scoliosis, but there was a study a couple of years ago now that looked at patients that were kind of in that 50-degree range that like either had surgery or didn't. And the patients that didn't have surgery had fewer back problems than the patients that did, right? Having all the screws and rods in your spine is not normal. I tell them, like, that's not normal. You're going to have some issues with that over time. It's just straighter and better and less likely to progress. But if you knew you weren't going to progress, you shouldn't choose surgery, right? It's that you don't know. And if so, somebody's in that, they're well above that threshold or reasonably above that threshold and still a teenager, I will do that on a curve magnitude, but that's the only ones that I do. Does that make sense?
Perfect. Thanks a lot, Dr. Koski.
And I just had one brief question. Do you use like the age appropriate sort of goals, like the stuff that has been published in the past couple of years?
I don't buy it. So, and the issue is this. So that cranial center mass study, we took 100 adults, 3 groups. It was 40 to 60, I think 40 to 60, 60 to 80, and above 80, looking at these different age groups for that. And these were asymptomatic patients, no back surgery, no back pain, no back problems. So we had to recruit, asymptomatic individuals. And those groups, the older population was a little bit in front. They were like 2 centimeters further forward than the 2 younger groups. So it was a little bit more forward, but not a lot. And then the ISSG says, they're 10 centimeters, more than these.
Yeah.
So they looked at patients coming to see them with back problems. So those are symptomatic adults. I don't think you can measure normals on somebody that's abnormal, right? So I think that study is flawed in doing that. So I don't think you can really say that that's the truth. Do I think older adults need to be more forward than younger adults? Absolutely. I would never try and pull like a 70-year-old back to an SVA of 0. I think that's too much, right? You might get them there because you overcorrected them, but I certainly wouldn't be trying to do that. I'm trying to leave them, like when I measured, I'm trying to be like 4 centimeters forward, which is still more than the norm. The norm for an adult there was like 2.5 in our study. But I'm trying to leave them at 4 to 5 because I think that's a kind of a normal place for them to be and function. And especially if they're way forward to start with. If they're 15 centimeters forward, I want to pull them back to like 6. They're going to be much better than they were and function well, but have less likelihood of junctioning over. But again, putting that lordosis where it's supposed to be, I think makes a difference there too.
Makes sense. Well, thanks. Any other questions from other people?
Tyler, I got one last question. Maybe this is a little bit esoteric, but so when you see people that come in that would normally have a normal spine or asymptomatic normally, right? But then they have a trauma and it changes their alignment because of the trauma. How aggressive are you at fixing that when you really don't know what their spine looked like the first time, right?
Yeah.
I mean, sometimes you can sort of predict it, but I'll throw out a couple of examples of sort of extreme ones. Some are the thoracic ones, right? But that are burst fractures that'll change alignment. And then some people, they get to their decompression or whatever they're doing and they kind of like, it looks pretty good, but it's definitely not perfect. And, I always wonder how many of those people long-term have trouble and how, maybe people should have been more aggressive up front. Or is that too much for them to be doing? Or like I had a patient the other day that had a bad pelvic fracture and she came in with a pelvic incidence of like 93 degrees or something like that. So that's bad. Like you can't leave her like that. Well, you can. Most people do.
Yeah.
But if you do,
that is
they're probably going to have a horrible problem. But I don't know if we have enough of those people out there to know how horrible the problem is.
Yeah. No, I think so. I mean, I think the location matters a lot. So somebody like that has a pelvic incidence, they have a sacral fracture and it drives their pelvic incidence up. That is a huge problem for somebody to stand and walk. For functionally, that's a huge issue. And I think if you can correct that, you correct that. Not easy to correct, but easier to correct.
and if
when
you
it's still
correct-
broken than it
Right.
is once it heals that way. Then it becomes.
And if you
really-
correct it, what do you, so, I mean, how I did it was I based it on what I guess your lumbar lordosis to be currently,
Yeah. I
right?
would-
So because you can't know what a pelvic incidence is originally,
right.
and I know our lumbar lordosis is compensatory for what that horrible pelvic incidence is,
Yeah.
but it's never going to get back to, I mean, it's super lordotic, right? But so it's somewhere around there, and you can say, well, average person's probably 65 degrees, but who knows what that really is, right?
Yeah. Yeah. So I mean, in those, you get as much as you can because it's not always easy to get it there. But I would try and, like, if you just said, hey, you have a person, they have this fracture, we have no idea what they look like before, what are you going to make their pelvic incidence? I would tell you try and get it under 60 degrees, because even if it's bad, if they have lumbar pathology, you can get somebody 60 degrees of lordosis and have them look relatively normal, right? You can match that up if you had to. Above there, it starts to become really difficult. There are people that have 70 plus degrees of pelvic incidence normally, but that's pretty rare. So I would, right, if normal's 52, I think somewhere in that 50 to 60 degree range. If you just don't know anything about the person, have to figure that out. Now, in terms of like thoracic spine and things, I think you go for better. Somebody has a cord injury and things like that, trying to do major correction at a time of cord injury, like, boy, it gets to be a slippery slope, and it can be difficult. So like a fusion or a kyphosis in the thoracic spine is kind of floating in the middle of a lot of segments that move, is much less functionally problematic than things that are fixated, like at the lumbosacral junction, where they can't compensate above and below it. So I think there's something said to trying to get it better and without adding neurologic risk, and but maybe not going for 100% straight. But I think it matters. Like burst fractures that are kyphotic is a reason that, if you have progressive kyphosis, you treat that, because it ends poorly if you just let it be.
Yeah, I mean, it's interesting because I think they're sort of a different animal, because there's something obviously that happened to that degenerative scoli to progress like that, where these other people that are traumas, many of them are obviously young, but even some of the older people, they just don't have horrific looking discs, right? So they've got something that's not in that same protoplasm. It's interesting though.
Yeah. Well, good. Thanks for really hanging in there all this time.
Thanks for the lecture. I really enjoyed it.
Yeah.
Thanks, Tyler. Have a good evening.
Have a good evening, everyone. I think we have another lecture next week, so we'll send out that link.
Cool.
See you. All right. Bye.
Bye.